Evidence-based indications suggest that 73% of all lung cancer patients would benefit from radiotherapy at diagnosis. So in 2001 to 2, the radiotherapy utilization rate for lung cancer in New South Wales was 39%. Since then, the number of linear accelerators in New South Wales has increased from 29 to 46, and correspondingly there's also been an increase in the number of lung cancer multidisciplinary teams. We aim to evaluate whether this increase in resources had resulted in any change in radiotherapy utilization for lung cancer over the last decade. This was a data linkage study. Patients diagnosed with lung cancer between 2009 to 11 were identified from the New South Wales Central Cancer Registry. This data was then linked to the admitted patients data collection, the retrospective radiotherapy data, and clinical cancer registry data, in order to maximize the clinical information about the patient, which may influence indications for radiotherapy treatment. Radiotherapy utilization within a year of diagnosis was measured. These graphs show the utilization of radiotherapy by pathology and stage. And as you can see, radiotherapy utilization increased significantly in stage 3 and 4 non-small cell lung cancer and across all stages of small cell lung cancer and for those with no pathological diagnosis. However, if you look at the last bar graphs on those for each graph, the radiotherapy utilization is similar overall for both time periods for non-small cell lung cancer. It is greater for small cell lung cancer and less for those with no pathological confirmation. This is because patients included in the analysis by stage only comprised 37.8% of the overall population. So in that 37.8%, they had adequate staging data, performance stage data, and surgical data to enable calculation of the radiotherapy utilization. So in that cohort of patients, the radiotherapy utilization was quite good, 71.9%, but this contributed to 27.2% in the overall lung cancer population. In the remainder of the patients, the 62.2% did not have adequate staging or other data to enable utilization by stage. And in this group of patients, the utilization was only 23.6%, which contributed to 14.7% overall. So when you look at the whole group, the radiotherapy utilization was 41.9%, so a minor improvement from the 39% documented in 2001 to 2. On multivariate analysis, radiotherapy utilization was significantly lower in females, in those with localized disease, in older patients, especially those aged 70 years and older, socioeconomically disadvantaged patients, in inner and outer regional patient residents, and with increasing distance from a radiotherapy center. So, although an increase in radiotherapy utilization was noted for specific groups of patients, the overall utilization over the last decade shows minimal improvement despite an increase in radiotherapy resources. Why could this be? There has been an increase in lung cancer incidence during this time period, and it may be that the increase in resources has not kept up to pace with this. The poorest utilization was seen in patients with a significant lack of staging or other data, and a large proportion of these may not have been seen at oncology centers, which are likely to record this data. So it may mean that there's not been much change in the referrals to radiation oncology during this time. We also know that stigma and nihilism is well documented in both clinicians and patients with lung cancer due to its association with smoking, and patients who are not surgical candidates may not be referred for consideration of non-surgical therapies. Older age and increasing distance from radiotherapy centers remain significant predictors of radiotherapy underutilization, which is similar to what was reported in the breast study presented previously. When we compared the estimates of the optimal radiotherapy utilization being 73% to what was seen, about 42% in the study. The calculated shortfall potentially resulted in 312 patients having local regional failure and 157 patients having poorer survival as a consequence of not being treated with radiotherapy. Thank you.
Thank you very much, Shalini. Does anybody have any questions today?
Thank you for the presentation. The issue around stigma, and I'm just more clarifying what I think I heard, stigma and not picking up, following through with radiation therapy, or even that's for the patient and family. Did that actually get measured? Did you get a...
No, this is a pure data linkage study. They were just my possible explanations of why patients may not be referred to radiotherapy, because it is something I see in clinical practice. If patients are not considered surgical candidates, then sometimes they're not considered for non-surgical therapies. Like if you can't have surgery as a cure, well, that's it. I see that, yeah.
Yeah, okay.
So now that you've got that data, what are you going to do with it next?
Present it back to the Cancer Institute. No, this is part of an overall study being done on all for radiotherapy utilization across all cancers, which will be fed back to the Cancer Institute. But it does raise an interesting question. You know, how do you improve radiotherapy utilization if we've got increased resources? And there was an earlier talk by Dr. Gabrielle in the other room about that, and the fact that we do have more lung cancer multidisciplinary teams, but obviously we still need to do more, perhaps targeting GPs and patients to say they are, you know, lung cancer is a survivable cancer and there are treatments available which can do that, and you know, you should seek well, yeah, I guess I don't know how to advertise what treatments are available except for the Cancer Institute various websites, but yeah.
Okay, well, thank you very much for that.